Hi there, everybody. I'm Dr. Christina Hibbert. I wanted to take a minute today to answer some questions I've been receiving about one of the most misunderstood of the perinatal mood and anxiety disorders, postpartum obsessive-compulsive disorder. Now, in my previous 3-minute therapy series, you can find short videos on what postpartum obsessive-compulsive disorder is, how you can find treatment or what kinds of treatments are available, and how you might come around to the right diagnosis. Today, I wanted to go a little bit deeper into that though, based on some things that have come up in the past few weeks and this past month. I recently was at the Postpartum Support International conference, which they do every year. And this year they introduced a third day to their 2-day training for perinatal mood and anxiety disorders. Now, this is really cool because they're training providers to get certified in perinatal mood and anxiety disorders treatment. So you can look for that if you are a person who is looking for some kind of treatment and help and a provider, you can start looking for that certification. So this was the first time that we've done this. And in the course of teaching about the different diagnoses and talking about postpartum OCD in particular, some comments came up. And even afterward, in person and through emails, I had so many questions about postpartum OCD and how to treat it, how to really treat it. So in the 3-minute therapy video, which you can find the link for below, you can go and see that there are different kinds of treatment. But the research shows that one of the most useful forms of treatment is a combination of medication or psychotropic medications to help calm the anxiety and the thoughts that go along with that anxiety with OCD thinking, and then therapy. And specifically cognitive behavioral therapy, which many of us know as being the thought-based therapy. And it is. It's a thought-based therapy. It usually works to try to help us hear the thoughts that we're thinking, to challenge them, to change the ones that are unhealthy, unhelpful, or untrue, and to replace them with something that is more healthy, helpful, or true. The other part of cognitive behavioral therapy is what we call exposure therapy. And this has been a very highly validated method for OCD, traditional OCD, in the past. And it's still one of the go-to methods that most of us use. If you do cognitive behavioral therapy like I do, you would use this method of exposing somebody, let's say someone who, in traditional OCD would be afraid of germs. So over time, we might expose them to not being able to wash their hands as much and not being able to shower as much or not being able to wash their clothes as much. And that is the typical type of treatment. Now, here's something that I've learned over the years, and here's where we get a little tricky in this. There are different types of postpartum OCD as far as I have seen in my clinical practice. Now, again, this is just for educational purposes and to share some of the things I've learned clinically in my experience over the past 15 years working with this population. And one thing I've noticed is there's kind of 3 different presentations that you might see of postpartum OCD. So this can be helpful for not only you moms out there or dads or partners or families who are trying to help mom get help to understand what's going on with you, but also for any of you providers out there that might not be sure sometimes what you're dealing with. And is this really postpartum OCD versus regular old OCD, or what is even the difference and what does it even matter? First of all, there is the traditional OCD, which we think of when we think of, mostly people who are struggling with, germs and fear of those kinds of germs. Now that can be either a first time onset in postpartum. So it might be the first time ever that a mom has experienced any symptoms of OCD, or maybe she had some little symptoms and some anxiety. Usually that's the case. There's some sign of it before, but she just hasn't ever received a diagnosis or received treatment for it. And then in pregnancy and postpartum, because of the stress of everything, because of the sleep deprivation, because of all of the other factors going on, it starts to come out and it might become a full-blown OCD disorder, obsessive-compulsive disorder, which might have symptoms more like the traditional symptoms of being afraid of germs, but it usually still revolves around the baby. Okay, so this is something that, for instance, a client that I worked with who was had some symptoms of OCD, had some anxiety before, and it wasn't until pregnancy when things started building. She started to become terribly afraid that something she was going to eat or do or touch was going to contaminate her, was going to contaminate the baby. Then after the baby was born, it became full-blown just a nightmare for her because she was spending so much time every day washing the baby's clothes, washing her own clothes, taking showers, washing her hands, disinfecting everything multiple times a day. When she was pumping for breastfeeding, she would disinfect the pump. At first it was just boiling it and disinfecting it, and then it was boiling it, disinfecting it after every single use, and going through this whole process. So she's spending all this time per day, even, making rules like, her partner couldn't come into the house, couldn't even come into the garage with his shoes on, but had to take his shoes off and then go through a process of taking all his clothes off because he worked at a hospital and she was afraid he was bringing in germs. So you can see where that sounds more like that traditional type of OCD where it's really germ focused and contamination focused and that fear-based related to germs and contamination, but it's really also related to the baby and harm that she's going to somehow kill the baby because they're going to let some kind of illness in or some kind of infection or something. So that's one. Then we have what I would call more of a traditional postpartum OCD, which again, if you haven't learned about this, please go watch the other videos so you can understand, but which includes those symptoms of, it's not so much germ-based, although that could be there, but it really is these mental images and thoughts that are so vibrant and vivid, it's almost like a movie being played in the woman's head. And she's trying to, stop it. She doesn't want to see it. She doesn't want to have to see these images, usually related to some kind of harm coming to her child. It's just like a picture or a movie of, I had one client who was pregnant, went to the, so seeing these images in her mind, and for instance of, all of us, when we have our children, we might feel afraid for them. We don't want them to fall. So when we go past the stairway, we hold them tighter, right? But in this case, they would not only hold them tighter and maybe feel some kind of nervousness, but maybe see an image of the baby falling and smashing on the ground. Now, this is postpartum OCD, and it's very misunderstood because of these vivid images that seem so scary. And as I emphasized in the other videos, it is not psychosis. And the way we know that is because the woman knows these thoughts are not okay. She is in high distress. She has incredible anxiety. She's questioning all the time, am I losing my mind? Am I going psychotic? What is wrong with me? And someone who has psychosis, by definition, means they're out of their right mind. They don't understand what right from wrong. They don't know that something's up, and they would seem very calm if they were having these kinds of thoughts. It would be what we call ego syntonic, or helpful to yourself, or it feels good to you, versus ego dystonic, which means it doesn't feel good to you. It doesn't feel right. This is wrong. So this is more of the traditional postpartum OCD. And what I've found is some providers might, at the beginning, sort of misdiagnose or misunderstand those that have more of a traditional presentation of postpartum OCD that was triggered postpartum, and it still is diagnosed as postpartum OCD, even though the presentation looks different, and it can be a little bit different in how we actually treat. Okay, so that's why this is important too. And to remember that it really has to do with what's the focus of the thoughts or the worries and the fears, and did it start in pregnancy and postpartum? Is it intensifying in postpartum? Then it is a postpartum OCD. Even if it's a traditional OCD type of presentation with germs, it's still a postpartum OCD. But we just see these two different types. And then there's a third type of person that I wanted to talk about, which is a client that I had who had been diagnosed with traditional OCD. So she had OCD symptoms of lots of, fear of germs, fear of contamination, and was doing the typical things that you hear, hand washing so much that her hands were raw, spending so much time with all these rituals that she had to do in order to keep herself clean and protected. And OCD doesn't always have to do with germs. That's not always what it is, but it is a fear. There's a fear of something, right? So she had this before, then she got pregnant and she was doing okay. And then toward the end of her pregnancy and definitely into postpartum, the postpartum OCD started to happen, the traditional postpartum OCD that I was talking about with the vivid images. So she had had a combination of both, and this you might find as well. Now, the reason why I bring these up is because here's what's important to know. When we treat OCD, oftentimes providers use what we call exposure therapy, which I just talked about, in addition to cognitive behavioral therapy. So you might use, with all of those three different clients, different people, you might use the same type of cognitive behavioral therapy. You might use a thought record to try to help you understand what's going on in your mind and what are you thinking and what are you thinking about what you're thinking and what are you feeling and how do those things relate, and then to help you work through and find alternate ways to think. And you can find a free copy of Thought Records Part 1 and Part 2 on my website, drchristinahibbert.com, and there's a link for that below. Now, if you want to use those. But also, you might use exposure therapy because it's very highly respected and researched for OCDs in particular, and for fears and anxiety. Now, what I've learned is this. The problem is that a lot of providers can get it wrong and think that what we're trying to expose you to in postpartum OCD, the traditional postpartum OCD, is the actual thoughts and images. In other words, I learned this from my client who was the one that had traditional OCD, let's call her Katie. Traditional OCD and then postpartum OCD. When she did her traditional OCD, she went to treatment and she was great at treatment. She really, really worked hard. She was able to manage her OCD through therapy. And in that therapy, she did a lot of exposure therapy. So it was exposing herself to the fears of the germs by not letting her wash her hands, by not letting her perform the rituals and making herself have to stop doing those things that she was otherwise spending so much time doing. The problem was when she started with postpartum OCD, she had such a great background in exposure therapy, she started to try to do the exposure therapy for herself. And that meant she was trying to make herself think about these thoughts and images all the time. She was trying to bring them up and trying to imagine them and trying to focus on them. And that was just making it much, much, much worse. So because of what she was doing, trying to expose herself to the thoughts and images, it was bringing up so many more fears. It was making them come more often. It was just making her miserable. And so we learned that there is a difference, okay? What we're trying to expose the client to in exposure therapy is not the vivid images themselves, okay? We're not trying to make them think about the worst possible case scenario or think about all those things. Those are just, we can just group them as the thoughts or the images or whatever. We don't need to know all the details. We don't need our clients to be focusing more on the details of those. What we need them to be doing is focusing on the thoughts, the experiences, the feelings that lead up to those experiences where the images come, and their response after, and helping them to expose themselves to the feelings of anxiety and fear that they're otherwise trying to avoid by doing the compulsive behavior. So with a traditional OCD, the compulsive behavior is to wash the hands because the fear is that I'm going to be contaminated by germs that are on my hands. So when we prevent them from washing their hands, then they have to learn to deal with the anxiety they feel. And that's part of exposure therapy, is relaxation techniques and stress reduction and other types of tools to help you feel the anxiety and let it be okay and not let yourself do that compulsive behavior. And in OCD, what happens is there is compulsive behaviors like burying knives in the backyard, or avoiding cooking because you've seen images of harm coming to your child in the kitchen and you don't want to even put yourself in that situation. Or I've had clients who have stopped sleeping in the same room with their baby and with their partner and want the door closed at night. So the exposure therapy is closed and locked, both doors closed and locked. And so the exposure therapy isn't to make her think more about the thoughts that are driving her to be afraid. It's to start exposing her to the actual, just the feelings of the fear and the anxiety. For instance, by exposing her to having her door unlocked, but the baby's room where her husband was sleeping, that door locked. And then working up that hierarchy to having both doors unlocked, and then having just their door open and her door closed, and then both doors open because she was afraid that these images she saw, she would be asleep and somehow not be able to realize what she was doing and go harm the baby, which we have no reports on record of any woman with postpartum OCD ever acting out on the images or thoughts. It's just not what this disorder is, versus psychosis, where again, there is a real threat, but it's such a rare percent of the population that have those symptoms. And also it is such an intense experience. Let's see. And also, they just don't know that they're not in their right mind. And you can tell a very distinct shift in how they feel, how it feels being around them, how they're acting, how they look, how their eyes are, their body posture, all these kinds of things. So again, OCD is not meaning that they're gonna have harm to their child. So we want to help try to expose them to the things that they're afraid of in their natural environment. Now, here is another thing that I've just recently heard about. After this conference that we did, one of the participants came and talked to me, and she had a client who had postpartum OCD. She had been working with her in her private practice, and it's, treatment can be slow. It does take time. But apparently this client's husband wanted her to get more help faster. So he checked her into an inpatient program, and they started doing cognitive behavioral therapy and exposure therapy with her. Now, the problem was that the client was still in contact with this woman I was talking to, her therapist, and still checking in, and was telling her that they were having her spend several hours in the afternoon reading articles, going online and looking up things about mothers who have killed their babies, who have harmed their babies. They were trying to have her imagine first, and then do for real life, like putting your hand around the baby's neck, because that was something that she had seen in an image. So they wanted to expose her to the fear that she saw in the image, which is that she would choke her baby, by having her put her hand there and show that she wouldn't choke her baby. Okay, are you following me? Okay, now this is where it gets tricky, and this is why it can be so difficult. I've even seen some information online from supposed professionals who are experts in this, who are giving misinformation and telling people that this is how you do it. You expose them to the fears by having them act out the things that they were seeing in the image, or by having them overindulge in thinking about the images or writing about it, or like getting all the details out, or going online and searching. Now, in fact, the opposite is true. I 100% tell clients who are OCD not to go online and search stuff out, because that is another compulsive behavior. They want to go search and see, am I going to become psychotic? Am I going to, is something going to go wrong? What do I need to know? And I help them get the right information and education, and then tell them, just don't go online, because it becomes a compulsion. So that's not healthy. And it's also, you can see where it's not, we've just got it wrong. Some of these providers just have it wrong. So if you, listening to this right now, if you are going in for treatment and you feel like your provider is giving you that wrong advice, please get a second opinion, a third opinion. Go try somebody else, okay? You have to feel comfortable with your provider, with what they're doing with you. And if your diagnosis is OCD, you should be in your right mind enough to know what kind of treatment is going to be helpful for you. And hopefully it's somebody who has been trained and who has maybe been certified by PSI, Postpartum Support International, and you can find out more about them at postpartum.net. And you can find providers who have been through these trainings, have been through advanced trainings. I do an advanced clinical skills training. So people who have advanced training in this that can help you with what you need. Now, so what do? We are not trying to expose clients to the actual things they're seeing in their image or to the images themselves more. What we're trying to expose them to is the fear and the anxiety that come when they can't engage in the compulsions. It's the same thing that we do with our germ-based, contamination-based. We try to have a hierarchy of things that make them afraid, and we go with the behaviors that they're exhibiting every day to try to change those behaviors by exposing them to the things they're most afraid of and teaching them skills to overcome the anxiety and deal with it and be able to sit with it and know that this is just anxiety. This is just fear. This isn't gonna happen just because I'm afraid of it. We don't need to do things that feel uncomfortable and scary, like pretending that you're gonna, putting your hand on the baby's neck, even though that mom wasn't going to harm her baby. I guess maybe she learned that, but she didn't feel comfortable with her treatment and she ended up leaving treatment. And so she went back to her other therapist who actually knows what she's doing and can help her in different ways. So you can see where there can be this misunderstanding with this exposure treatment and how we're doing it with OCD. And it's a tricky thing. I've had so many questions in the past few weeks since the conference asking about this. Like, okay, well, explain to me, what are we trying to expose the client to? And what, why do so many providers have this wrong? And I think it's because it's a little bit tricky because it's a little bit different. Having a very visible physical compulsion and obsession is different than having something that's in your head. You don't want to have somebody who's really struggling with what they're thinking and feeling in their head be stuck more in their head. Does that make sense? We're not trying to make them more in their head. We're trying to get them out of their head and get them out of those thoughts to see, you know what, every time I don't get enough sleep or I don't let people help me or I'm trying to do too much, the thoughts come more and more. Okay, so those are behaviors that we need to let you do. We need to help expose you to asking for help and expose you to, being able to take naps or get more sleep or find a pattern so that family sleep can be better. Or, what's happening after the thoughts? Well, after the thoughts and images, I freak out, I go online, I start searching, I stop cooking dinner, I stop sleeping with my family, I just do everything I can to stay away from the baby because I just think I'm gonna harm the baby. So how can we help them to get into that normal, natural routine of being the mom of this baby and helping them see, because most of the time, these moms really are taking good care of their babies. They're just afraid. So they'll take very good care, but then they're afraid. So they might be a little more hands-off or try to have others get in there to help. So how can we help you to interact with your baby so that you're not afraid? And you can see where if someone's telling you to just put your hand on their neck and show yourself that you're not going to strangle the baby, that would make you afraid. And so it's just the wrong take on it. I hope this makes sense, okay? So, bottom line, make sure if you are a mom, a family member, a friend of a mom who's struggling with this, please seek guidance and help. Go to postpartum.net. You can look up your state. You have a coordinator in all the 50 states in the United States and also in very many countries around the world. So there's somebody that's in your area that has been trained, that is volunteering, has been through this and is healed and can help you. So go start there to find the right providers that you need. And second, don't be afraid to get a second or third opinion. Okay, if you don't like the treatment, try somebody else. Even if they say they are 100% an expert. I've had so many actually legal cases that have come up and also just people that I've heard from who have gone to quote somebody who says they're an expert in this. And even a place where I used to work started saying that they were experts in this because I had worked there, but they had never gone to training. None of them knew anything. And when I left, there was no expert there. So it's something that people say, and it doesn't necessarily mean that they're good at their job, right? It's just like you can have an expert at anything, doesn't mean that you're going to resonate with what they're trying to do with you. Okay. So be willing to take that step to find the right treatment and to keep looking. And for those providers who've been listening, I hope this has been helpful. And I welcome any of your questions to keep this dialogue going, perhaps down in the comment section, because I do think this is a really tricky issue. And this certainly doesn't answer every question. And I'm not the all-knowing authority on this. These are just some things I've learned and some education I'm passing along. And of course, this does not take the place for proper diagnosis, proper treatment, proper care from your medical and mental health providers. And I just hope this has been helpful. So please be sure to subscribe to my channel here, Dr. Christina Hibbert, for more videos like these. And let me know your thoughts. Let me know your questions. Let me know what you want to hear more about. Again, this video came from questions. So ask me what you want and I'm happy to help you out. And be sure to check out the 3-minute therapy videos with the links below and the other ones, as well as Motherhood Radio podcast. And the TV episodes are here on the YouTube channel as well. And visit drchristinahibbert.com. And we'll see you next time. Bye, everybody. Especially for you moms and families and support people, visit my website, Dr. Christina Hibbert, and you can learn more about my new online course, PPD Empowered, where we talk about all of the different things that you need to know about perinatal mood and anxiety disorders and what you can do. So you can check that out there. And for you providers, be sure to check that out and recommend it and pass it on to your clients, as well as you can check out more about my advanced clinical skills workshop on the postpartum resources link on the homepage at drchristinahibbert.com. And if you're a provider, you might want to check out my advanced clinical skills workshop that you can find out about at drchristinahibbert.com. You can go look under the postpartum resources and find a link for that there. So just like in traditional exposure therapy with traditional OCD, you're not actually exposing them to the thing they fear. You're not making them have to sit there and touch Ebola virus or whatever they're afraid of, the flu, or whatever kind of thing they fear, contamination. No, you're not doing that. You're exposing them to the behaviors, preventing them from using the behaviors most of the time that help to avoid from having to feel the anxiety. Does that make sense? So we're not going to expose people that have thoughts of harming their children to anything related to harming their children, reading about it, thinking about it, focusing on it, pretending or proving to themselves that they won't, just like we wouldn't expose somebody else to the actual germs. We're exposing them to have to not do the behaviors that they do to make them not have to deal with the anxiety, right? So in other words, we're exposing them to the actual feeling of anxiety by preventing them from doing the behaviors that have been compulsive behaviors, if that makes sense, okay? Checking online or whatever it might be, okay? Hopefully that makes sense.